Hey everyone, welcome back to PS Platypus. Today we're going to be having a look at some anatomy of the ear, as well as having a look at the infratemporal fossa and pterygopalatine fossa, two important anatomical spaces that will be talked about in your anatomy lectures. So let's get started. In these slides, we're going to be covering some basic ear anatomy with the outer, middle, and inner ear structures, the neurovasculature of the ear, very briefly as well, the tympanic cavity, a very important point to have a look at, a visceral space inside the ear, the eustachian tube, as well, is going to be an important one to take a look at, and the auditory ossicles, the hammer, anvil, and stirrup, or the malleus, incus, and stapes. We're also going to be having a look at some physiology with how hearing works and the physiology behind that, as well as balance. And we're also going to be having a look at the fossae, so the infratemporal and pterygopalatine fossa. And throughout these lectures, just to make it a bit more relevant for your learning, we're going to also throw in a bit of clinical context with otitis media, mastoiditis, or ear infections, as well as the hearing test that you'll be expected to know for cranial nerve testing. And then finally, otoscopy is technically a topic within ear anatomy, but we're not going to be covering it here because it deserves its own lecture. It's essentially looking into the ear and looking at the eardrum and other adjacent structures, but it's something that you'll be covering more in your clinical skills lectures. So we'll leave that for now. Let's first have a look at the anatomy of the ear. So in terms of the basic anatomy, there's three sort of parts of the ear. You have the outer ear or the external ear, which consists of the fleshy part of your ear, which is the auricle or the pinnae, and the actual canal of the ear. So that's the external auditory canal or the external auditory meatus, whatever you want to call it. Essentially, everything from the outside of the ear up to the eardrum is your external ear. So that's from here all the way up to here is your external ear. So quite a long segment of the ear is just the external ear. Then the middle ear is composed of everything after your eardrum, so behind the eardrum. So that's your ossicles, your malleus, incus, stapes, or your hammer, anvil, stirrup, up to the actual inner ear itself. So the inner ear is sort of formed behind this wall of the middle ear. So that's the middle ear here. That's your external ear here. And then you have your inner ear as being this structure here, which is essentially the vestibular cochlear organ. It's the actual organ that will be able to translate sound waves into electrical impulses and also be able to compute things like position for your balance and send that to the brain as well. So that's your external, middle, and inner ear all done, right? And then you have your neurovasculature. Again, it's not too high yield here to look at the arterial supply because it's quite a rich arterial supply. And so there's no real significance in having to learn exactly which branches supply it. But just for your own knowledge, the external carotid artery and the internal carotid artery both supply the ear. They have their own branches that supply it. So there's a posterior auricular, which makes sense for supplying the ear, superficial temporal, occipital, and maxillary. And then internal carotid is supplying the ear via the labyrinthine branches. All right. Now, the nerve here, though, is very important because it's a nerve you'll be testing time and time again in cranial nerve testing. And it's cranial nerve 8, which is the vestibular cochlear nerve, which is going to, again, take information about balance and hearing from your ear and take it to the brain. So you'll be testing that quite commonly in cranial nerve testing. Now we come to another bit of important anatomy, which is the tympanic cavity. So essentially, if you look back at the previous slide, the middle ear, that space that lies between the eardrum and the inner ear, we're looking into that space and defining some more of its structure and boundaries. So first of all, that tympanic cavity or the middle ear is often demonstrated in a diagram like this in your textbooks and in your anatomy classes. But it can be kind of a difficult diagram to understand because it's hard to figure out where we're looking into and what we're looking at. So the way that I sort of explain it is imagine you're looking into your ear, but you're taking out the eardrum. So you're looking from lateral to medial rather than medial to lateral. So just a quick change to that statement there. I should say lateral to medial. You're looking into your ear, but you're having the eardrum removed so you can look into the space behind it. You're also removing the ossicles as well, which is why you don't see the bones themselves there. But you're looking at everything that would be left behind if you removed the eardrum and ossicles, right? If they were there, you'd see some bones here that are the ossicles, and you wouldn't be able to look in because the eardrum would be covering it, this opaque membrane. The membrane covering it would sort of limit you to be able to see inside. But now that we know what we're looking at, that we removed these two structures to be able to look into the ear, we can start to understand what we're looking at. So this is, again, the middle ear cavity, or tympanic cavity. The far end is your medial wall. The end close to you, coming out of the screen, would be the lateral wall with the actual tympanic membrane that we've peeled off and removed. This here is anterior, that's posterior, up above is superior, and below is inferior. So easy enough to understand where we're looking at and what we're looking into. So now we come to talking about the actual walls themselves. The far end, again, was the medial wall, and that is, oh, actually, we'll start at the closer end, which is the lateral wall, because that's the one that we've removed here, so it's easy enough to understand. That's the tympanic membrane, the one that we've peeled off to be able to look in. So that's the lateral wall, also called the membranous wall because it's the tympanic membrane. The medial wall is the far wall, and that is the wall that separates the middle ear from the inner ear behind it. So that's why it's called a labyrinthine wall, because the inner ear's labyrinths lie behind this wall. In terms of structures, again, we've removed all of the bones. So stuff that's left behind, so the ossicles we've removed, stuff that's left behind includes the oval window, which is the window or part of the inner ear where the stapes attaches, which is that final bone in the ossicle series. Then you have the round window, and again, we'll cover the significance of that in the physiology of hearing. We have the promontory, which is the bulge of the cochlear organ, sort of against that wall. It lies behind it, but it makes that bulge laterally. And then you have the tympanic plexus, which is a plexus of nerves that are formed on this promontory. And then you have the prominence of some structures such as the facial nerve, which runs through the facial canal, and the semicircular canal, which is again your inner ear structure that's sort of bulging through this wall. So you can see there's quite a few things here and there with the tympanic cavity. Then if we look at the floor, the inferior wall, below it is the internal jugular vein, which is why it's called a jugular wall. I'll explain exactly how the internal jugular vein and the external and the internal carotid artery sort of relate anatomically in the next slide. But for now, just take my word for it that the inferior part or below this wall is the internal jugular vein. And you can appreciate that on this diagram here and the diagram over here as well. And then the roof, the superior aspect, above it, as you can imagine, would lie the cranial fossa and the brain, right? So you can see over here, the roof, above it would be the brain. And over here, above it is the cranial fossa, the middle cranial fossa, and then above that would be parts of the brain. So the roof is called the tegmental wall because that segment of bone is called the tegmen tympani, or it's a part of the temporal bone essentially. And then the anterior wall again, which is this one over here, contains the eustachian tube, which is a little opening, also known as the pharyngotympanic tube, that allows this middle ear cavity to communicate with the nasopharynx. So it's a tube connecting your middle ear, right, to your nasopharynx. And so you can imagine that it's sort of a tube that runs anteriorly, so it goes forward, and also medially, so it's running like that, right? Which is why in a diagram like this one, it looks like it's almost just running medially. But in fact, if you were to look at it from the side, you can see it's got a bit of an anterior tilt to it too, which is why over here in this diagram, it looks like it's going anteriorly, but it's sort of an anterior medial tilt or direction that it's running in. I hope that sort of makes sense. Essentially, it connects the middle ear to your nasopharynx. I'll talk about that a bit later on as well. So that's why it's called the eustachian tube or pharyngotympanic tube. And also on the medial aspect is the internal carotid artery. Again, we'll cover how the arteries and veins relate anatomically to this space, but for now, just take my word for it that it's on the anterior wall. On the posterior wall, so at the back, we have the mastoid air cells lying behind that wall, and so we call it the mastoid wall, which is essentially the mastoid bone lies behind your temporal bone, or posterior temporal bone. And the opening that leads into the mastoid air cell spaces is called the adductus mastoid antrum. Harder to appreciate in this diagram here, again, because posterior would be behind these bones and you can't really see that well behind it. And the other thing that's here is the tensor tympani muscle, which you can see the pyramidal evidence of here. Essentially, it can contract and sort of dampen the vibrations of some of the ossicles and therefore limit the damage that comes from very loud noises. But we'll talk about later on when we have a look at the ossicles in a second. So that's all of the anatomy of the middle ear. It's quite a bit. Just take a look at it again and see if it all makes sense. And feel free to leave a question or comment on the video or on our messenger as well. Here on the left, you can also see my poor attempt at trying to explain how the vessels come into play here. So you can see how the internal jugular vein and the internal carotid artery, they start off as sort of structures that are held closely together within the carotid sheath in the neck, right? If you remember the neck anatomy, we had those two vessels lying within the carotid sheath, running in the neck. And then once they reach the skull, they separate, and the internal jugular vein, you can see how it very exclusively sort of falls under the tympanic cavity. So it goes under it first, right? So that's why it's the inferior wall in this diagram. But then it sort of snakes its way around and ends up running posteriorly, right? It goes sort of posteriorly and runs behind the middle ear. So if you were to extend the internal jugular vein here, you expect it to then end up going somewhere behind the ear, right? But a bit sort of on the medial aspect and further away. So it actually would be behind the ear, so there, which is a bit hard to wrap your head around, but I hope that sort of clears up with the internal jugular vein anatomically relates to the middle ear space. It sort of goes inferior, snakes its way around posterior somewhere here. And then the internal carotid artery does a different thing. It sort of runs posteriorly, right, which is, anteriorly, which is the confusing part of this diagram. This over here is anterior, that's posterior, which is why it looks anterior here. But then it snakes its way around and runs sort of anterior medially, which is why you see that over here. So it sort of runs like that and then runs anterior medially. I hope those combination of diagrams helps clarify where the vessels lie in relation to the tympanic cavity. If not, just have a look at them and see if you can piece together those bits of anatomy in your head. Or better yet, have a look at your specimens, cadavers, 3D models, and they should clarify how this all fits in together. So that's your vessels and how they relate to the tympanic cavity. And next, we're going to move on to some easier bits of anatomy, which is the eustachian tube or the nasopharyngeal tympanic tube. And that's connecting the middle ear to the nasopharynx. So you can see here that it's this little tube that connects the middle ear section to the nasopharynx. And if you find this a bit confusing, like what's this tube over here? Remember, this is the actual external auditory canal. And then behind the eardrum is the middle ear. And then this tube is the actual eustachian tube bit. So don't confuse this outside tube as the eustachian tube. That's the actual external auditory meatus. So you can see over here again, the middle ear. On this side is the external auditory meatus. But then running sort of anterior medially from here is the pharyngeotympanic tube connecting to the nasopharynx. Why is it important? Well, it actually allows for drainage of fluids from the middle ear to the nasopharynx, and then you just swallow it or cough it away, and then you can get rid of that fluid. However, children, as you notice here, have a shorter tube because again they're smaller individuals, and the tube is more horizontal in them. The horizontal bit is especially important because the fact that it's horizontal means it's very poor at draining fluids, and that means that the fluid is more likely to pool within the middle ear. And remember, stasis is the basis for infection. You're going to have a higher rate of infection with the middle ear, which is why we expect the rates of infection with the ear to be higher amongst infants than there are with adults, which is the case. That's the clinical context of the eustachian tube. Then the auditory ossicles are essentially the bones that compose your middle ear, and they're consisting of the hammer, anal, and the syrup, which is more scientifically or anatomically called the malleus, incus, and stapes. That's starting from the lateral end, the eardrum end, working your way medially. The malleus, the incus, and then the stapes that connects to the inner ear. You also have some muscles that actually allow you to protect these bones and the ear itself. Because if you imagine, if you have very, very loud sounds and the bones are vibrating quite intensely, they can actually damage the inner ear. So these muscles are the tensor tympani muscle that we covered before that was forming part of the posterior wall of the tympanic cavity, as well as the stapedius muscle. These have different innervations, which are embryologically important. And if you want, you can have a revisit of the embryology slides and see why they're important. And the reason is they come from different regions of the arches. So tensor tympani is therefore innervated by a higher up nerve, which is cranial nerve V3, trigeminal, and it's going to pull the malleus and tense the tympanic membrane and therefore dampen noise in that way. And you can see that muscle here, tensor tympani, right? And you can see also how it ends up forming the posterior wall, because this is the view that we're seeing. This is the posterior wall. It's sort of coming out of there and forming what's called the pyramidal emittence, but that's not too important to know. You also have the stapedius muscle, which is cranial nerve 7, and that's going to pull on the stapes as you'd expect and prevent vibration that way. So it'll just hold it in place, kind of like when you ring a bell and then you hold on to the bell, it'll stop vibrating. It's a similar function to that. Prevents the vibration and then dampens the noise that way. And you can appreciate that in the diagram up here. There. So it connects to the final muscle or the final bone in the chain of bones, which is the stapes. All right, so that's your auditory ossicles and your eustachian tube as well covered and done. We're now going to have a look at some clinical context to put it all into an application or into practice, essentially. So otitis media is an infection of the ear, but the middle ear. So that's the media part, middle, otitis being ear infection. So middle ear infection. The pathophys occurs largely in children because, again, they have shorter or more horizontal eustachian tubes that don't drain very well. And so that means the drainage from the ear to the pharynx is limited, or in other words, an upper respiratory tract infection, so one where your pharynx is affected, is more easily able to spread up into the ears. So there's two ways you can have the infection occurring. Either it originates in the ears, or it traveled up from the pharynx into the ears, right? And again, because it's going to have poor drainage, it's going to stay there, and stasis is the basis for infection. You're going to have a middle ear infection, otitis media. Again, we talked about why that's more common in children for the reasons of the nasopharyngeal tube being more horizontal and shorter. But from here, an important complication is that if you remember, we talked about how on the posterior wall of the middle ear cavity, we have what's called the antrum to the opening to the mastoid antrum, right? So it can actually spread from the middle ear to the adjacent space, which is the mastoid air cells, enter and infect those areas, and then cause a mastoiditis, which is an infection of the actual mastoid bone. And you can see that here in the diagrams where the middle ear infection has gone from just the middle ear to the actual bone behind the ear, which is the mastoid bone, right? So that's an important complication of otitis media, and it shows how anatomy has an application with actual pathophys of conditions. Complications wise, it can cause a lot of damage. It can cause the tympanic membrane to weaken and rupture, which is going to cause loss of hearing. You also have venous spread. So this infection can actually travel and make its way into the bloodstream. Usually the veins lie more closely to it. So it'll get into the veins, and then if it can actually spread through the veins to the actual brain itself, it can cause an infection of the brain of its meningeal layers or the brain parenchyma itself, causing either meningitis or encephalitis, stuff you will learn about later on as well in brain anatomy and in neuroanatomy. So treatment-wise, most of these are actually viral, and so they're self-resolving, which is great. So it means you don't have to really do much. You can just give them, pain relief, as other supportive measures, like if they're very dehydrated, give them fluids. But essentially, it's self-resolving. The only context where you might need to intervene is where it's a severe bacterial ear infection, in which case you might need to use antibiotics and even surgery to resect the infected parts of bone. Because they may be very severely infected. So that's otitis media and mastoiditis summed up. Now we come to some more physiology. So we're going to talk about hearing first, and then balance second. Hearing wise, you don't really have to know too much. Like, I'm not going to be covering the entirety of physiology. I'll only be covering what I think is probably the more important to understand at a base level. So generally speaking, the way that hearing works is you have sound or vibrations traveling through the air, and they get conducted through your external ear, which again, if you remember, is going to be collected via the fleshy part of your ear, sort of condensed or pushed into the external auditory meatus, and then eventually reach the tympanic membrane, the actual eardrum, right? And then once it does that, it'll get transmitted via mechanical vibrations through the middle ear ossicles. So it's gonna make the tympanic membrane vibrate and deflect, make the middle ear bones deflect and vibrate, and then from there it'll go malleus, incus, stapes. The stapes is then gonna move the oval window, which remember we talked about before is the place where the stapes connects onto the inner ear. Make the oval window move, and then the oval window will make the cochlear fluid inside the inner ear move, and then that will undergo a bit of complex physiology that will eventually convert those vibrations into electrical activity and impulses that will be sent up via the auditory nerve or the cranial nerve 8 up to the brain, to the auditory cortex. All right, so that is the supracochlear nerve, sorry, will be sent to the brain. And so that is a basic overview. In terms of what actually happens with all the fluid inside the inner ear, essentially what happens is the stapes vibrates, right, the oval window. So it makes the oval window move. Then the scala vestibuli, which is one of the fluid chambers, which contains perilymph inside it, will also vibrate because the fluid vibrates in response to the oval window vibrating as well. Then the basilar membrane, which is a membrane that lies within the actual inner ear itself, will also in response begin to vibrate. And the way that the ear works is that the lower frequency vibrations will travel further to thicker parts of the base, the basilar membrane, and the higher frequency vibrations will sort of come off earlier and make the basilar membrane closer to the eardrum deflect. So the lower ones go further down, the higher frequency ones sort of come off earlier. Yeah, and so that's what's happening here with the inner ear so far. And then once the basilar membrane starts sort of vibrating, the hair cells or the kinocilium on it also start to bend, and then there's this whole thing with ion channels opening and action potentials being generated. But essentially, in response to the hair cells bending, they create an action potential to the afferent fibers that's sent up via cranial nerve 8 to the brain, and then sound can return or leave from the inner ear because the vibrations are still there. It can leave eventually through the scala basalis and out through the oval or the round window in this case. That's a lot of physiology. Again, there's a lot of details here about how the hair cells themselves actually look and what structure they have with the kinocilium and sort of ion channels. But I won't go through that in this slide set because it's something that I think is covered quite well in your lectures, and you can have a look at it there. But this is sort of a basic overview of what happens step by step with each of the processes that involves hearing. Now, this is probably the most important part to take in. And you can see that even if you don't understand the hearing physiology too well, it doesn't really matter because these hearing tests are almost like independent of that bit of physiology. And you can very much easily learn it and be able to apply it to clinical scenarios. So the way it works is you usually get a 512 hertz tuning fork and you perform one of two tests. So the tests are the Weber's test and the René's test. It's often hard to remember which one's which. So one mnemonic you can use is René behind the pinne, and we'll explain what that means in a second. But the Weber's test, first of all, is a test where you strike your tuning fork, right, with the tonged ends. You strike it, and you place the base of the tuning fork on the person's forehead in the midline. So it can be on the forehead, or it can just be on top of the head, basically in the middle of the head, right? And then you ask them which side is louder. Is it louder on the left? Is it louder on the right? Essentially, if everything's fine and normal, you expect it to be the same on either side, right? Because you're striking it and placing it essentially right in the midline, so that both sides should be receiving equal stimulation. However, if someone does have a problem, whether it be sensory, neural, or conductive, then you can have one side sounding louder than the other. Let's talk about sensory neural first. And this diagram over here at the bottom, these three images is actually very useful for that. So normal, again, you have an equal amount reaching both sides. So again, it's making the bone, actually the brain, the skull, sorry, vibrate, and therefore making the inner ear vibrate. So kind of like bypassing the external auditory meatus and just going straight via bone conduction to the inner ear. If you have conductive loss, and again, conductive loss is where the conduction from the outside world through the external auditory meatus is affected. So it could be like an actual obstruction, it could be some other sort of damage. Then what happens is, strangely, it actually ends up sounding louder on that side. And the reason is that when your ears, or when one ear loses conductive power, it actually compensates for that by becoming more sensitive to bone conduction. And so even though it's lost the external conduction power, it becomes more sensitive to the bone conduction. And so this side will end up hearing louder than the other side. So conductive loss causes the Weber's test to sound louder on the affected side. All right. Sensory neural loss is to do with the problem in the actual vestibulocochlear organ. So even if that's impaired, it'll actually end up sounding quieter on that side, because even if it's able to reach the organ itself is damaged, and therefore there's going to be a quieter sound on the affected side with sensory neural loss, whereas the other side will sound louder. So that's important to understand. Conductive loss sounds louder on the effective side. Sensory neural loss sounds louder or softer on the affected side and louder on the unaffected side. Easy enough. Now we come to the Rinne's test, and this is where the mnemonic comes in, Rinne behind the pinnae. The pinnae, if you remember, was the fleshy part of the ear. And essentially what this test is doing is we're going to strike the tuning fork again, place the base of the tuning fork behind the ear, right? Behind the ear on the mastoid bone. And obviously, when it makes the mastoid bone vibrate, it'll make the inner ear vibrate, and they're going to be able to hear something, that vibration. But when they no longer are able to hear it, you then immediately take off the tuning fork and place it in front of the ear, and then they'll be able to hear it again, right? Because the tuning fork is still vibrating. It just isn't vibrating enough for bone conduction, but it is vibrating enough for air conduction to still work. So that's the reasoning behind it. You go from the pinnae, so behind the ear on the mastoid, you remove it, put it in front of the ear, and ultimately what we're trying to figure out is what sounded louder to the person. Was the air conduction louder? Was the bone conduction louder? And because our ears have been engineered to be optimized for air conduction, the air conduction should have sounded louder than the bone conduction to the person, right? So the normal test would be the air conduction being louder than the bone conduction. And now we're going to see what happens if you have a conductive versus a sensory neural loss. So again, normal, we said before, the air conduction sounds louder than the bone conduction. With conductive loss, because the conduction of the air conduction is affected, the air conduction will be weaker than bone conduction. And so bone is going to be louder than air. So you can see over here as well in the table, bone is louder than air in conductive hearing loss. In sensory neural hearing loss, right, air is still louder than bone because the air conduction pathway is unaffected. What's affected is the vestibulocochlear organ, but the air conduction remains intact. And so even though you have sensory neural problems, air conduction should sound louder than bone conduction, and you should have a normal Rinne's test. So that's a lot of stuff that we've covered. Let's try and summarize it all into one quick idea. Let's say that you have your left ear being affected by conductive loss. Have a pause and think about what you might expect in the Rinne's and Weber's tests, right? With the Weber's test, you put the tuning fork in the midline. Because the left ear has a conductive loss, the ear compensates by getting better at bone conduction from the top to that ear. And so the bone conduction from here, from the Weber's test, makes the left-hand side sound louder than the right-hand side. So with a conductive left hearing loss, you end up having left sounding louder than the right. And then if you do the Weber's test, again, you put it on the bone itself, then you put it on the air. Because you have a conductive problem, the air conduction, again, is going to be impaired. The bone conduction compensates and becomes stronger. Bone sounds louder than air. You're going to have a Rinne negative. If you have a left sensory neural problem, so this time it's the vestibulocochlear organ which is damaged in some way, or the nerve that's damaged in some way, then even if you put it on the midline, because the organ itself can't register the sound as well, the left will sound quieter than the right. And then you'll still have the normal Rinne's test where because the conduction is intact, the air will sound louder than bone as it normally should. So that is all that put into one place. And I hope the diagrams and the combination of text there hopefully clarifies everything. See if you can try and, on your own, figure out if what might happen if you have a right conductive and right sensory neural hearing loss, to see if it all makes sense. And now we come to the physiology of balance. Balance is a bit more complicated because there's quite a few components to it, but essentially it's governed by quite a few things, or quite a few parts. The first part is the vestibule, and the second part is the semicircular canals. The vestibule is responsible for detecting balance with translational motion. So again, translation is moving in straight lines, and you could think of there as being a vertical component to it and a horizontal component to it. And the way it works is essentially you have these things called saccules and utricles, which are these structures that can detect motion in a vertical or horizontal direction. And you can see over here on the right how it sort of works as well. This is the macula. It's got a similar structure. The way it works is that essentially it's got a bunch of hair cells on it, and then it's got this membrane on it, and then these stones, essentially otoliths, which are ear stones that sit on the membrane. And the stones are probably the most important part because the stones get pulled down by gravity. And so let's say you were to tilt your head forward, right? Gravity would pull those stones down and therefore deflect the membrane down and therefore deflect the hair cells, which are picked up as a forward movement by your macula in this case. So this is how the macular response changes in your head, right? And a similar thing or principle applies for the utricle and saccule, just in the vertical and horizontal directions. And that's how we get this combination of three axes, right? Vertical, horizontal, and then also in between as well. You can look left, sort of like that, and like that as well. Yeah. And then we come to semicircular canals, where that's more rotational motion. So that's where you're rotating your head around. That's detected by semicircular canals. And the way you're able to even close your eyes and know that you're rotating your head is, well, for one, that you can feel the muscles moving and know that your muscles are carrying out a particular movement. But also, if someone else were to move your head for you, the semicircular canals inside the ear are detecting the rotational motion. And you essentially have three of them, one for each axis, so the X, Y, Z axes, and you can sort of see them here in the diagram. They each aligned in different axes, and they pick up movement in those three different axes. And the way they do it is they have this crista ampullaris, which is essentially a structure that's able to detect the changes in rotation. The way it works is, let's say you were to rotate your head, right? The actual organ itself, the actual semicircular canal would move because it's part of your head. So if you move your head, the organ will move, but the fluid inside has a bit of inertia. And so it actually moves the opposite direction almost, or it stays stationary with your canal moving. And so it feels like the fluid is moving in the opposite direction to the canal. And that, again, deflects a bunch of hair cells, is detected as a rotational movement. And then your brain's like, oh, you've rotated this way. And that's how you know, and you're aware of your rotational movement. So that is semicircular canals summarized. And you also have a series of reflex tests, which are not too important to know about. You have the vestibulo-ocular ones, where essentially your eyes are able to fixate on an object in front of you. Even if you were to rotate your head, your eyes stay fixed on the object because of the vestibulo-ocular test and reflex. You also have the doll's eye testing, which is a similar thing for a person where you're testing it in the case that they might be having a brainstem issue. Essentially, let's say they're not conscious. If you were to move their head, right, then the eyes will also like move in the opposite direction because that reflex is kind of still intact, and it's called doll's eye testing, because it means the brainstem reflex is controlling that is still intact, even though they themselves might not they might not be entirely conscious just yet. So the brainstem reflex is intact. And caloric testing is also another interesting idea of like testing the brainstem function, and that these nuclei that govern these things are still intact. Essentially, if you pour cold water into one of the ears, it again causes the fluids to move in a particular way that causes the your brain to move your eyes in the opposite direction, and hence the mnemonic cows, where cold makes your eyes go in the opposite direction and warm makes your eyes go towards that side. The way I sort of think of it is like kind of like a evolutionary reflex or reaction where you go away from the cold and towards the warm. Not entirely accurate, but it works for the purposes of knowing it for the exams. And so that's another reflex you can use to test for intact brainstem function with those nuclei. And that's pretty much all of balance summarized in these slides. There's also always, again, a bit more nuance to it. You'll learn about, again, how particular ion channels work and how they are bent and deflected to produce action potentials. They're covered quite well in those lectures. I won't go into it too much here, but again, you can refer to these slides to get a bit of a more summarized view of what you should know in terms of the basics for your exams. And now we come to the infratemporal and pterygopalatine fossa, the last bit of anatomy. And again, we'll start off with something that we already know, which is the temporal fossa, which is essentially this large fossa here, composed largely of the temporalis muscle. And you can see that it contains the temporalis muscle, first of all, but also the deep temporal nerve and artery, middle temporal artery, the maxillary artery, and the zygomatic temporal branch of cranial nerve V2, trigeminal nerve. That's the contents of it. Essentially, the way I think of it is like this big section of your temple that is lying above the mandible of your, lying above the ramus of the mandible. So this is the mandible, right? And it's lying above the ramus of it. And below that, below the ramus, is actually where the infratemporal fossa is. So above it was the temporal fossa, below it is the below temporal fossa, which makes sense. And it lies between this ramus and the wall of the pharynx, right? It's hard to see here, but if you look at some models or cadavers, it'll be easier to see how the pharynx fits in relationally. That's the infratemporal fossa, and you can sort of see it here. I've tried to label it on this diagram. And in terms of the other adjacent fossa, the pterygopalatine fossa, that's something that's actually sort of deep within the infratemporal fossa. You can sort of see it just there. And then within it also the sphenopalatine foramen. But you can sort of see how it communicates medially with the nose, the eye, the middle cranial fossa, with all these different connections. Like, for example, with the eye, there's like the inferior orbital fissure here. With the nose, it can also communicate it with it through the where is it? The sphenopalatine foramen, and the middle cranial fossa similarly as well. There's also the maxillary nerve here again, and artery and pterygopalatine ganglion here as well, which is something that you might cover more in the parasympathetic ganglion. But again, all this bit of anatomy is something that I think is more helpful for you to be able to make your way through specimens and cadavers and that sort of learning. It's not entirely useful for putting it into clinical context. And so I haven't put too much on the slide either. So that's basically it for the entirety of ear anatomy. If you have any questions, concerns, or feedback, please let me know, and I'll try and address them as soon as I can. Otherwise, we'll leave you to it.